Good morning, good afternoon. I'm Flora Peyvandi, Professor of Internal Medicine at the University of Milan, and with my postdoc, Ilaria Mancini, we have prepared an educational course on diagnosis and management of patients affected with thrombotic thrombocytopenic purpura. The source of information which I'm reporting is based on what has been published by the Ichttp Guideline on management of patients affected with TTP. I will bring TMA and differential diagnosis of different diseases in a class of TMA. Then I'm going to point out thrombotic thrombocytopenic purpura by definition, epidemiology, pathophysiology, and how we're going to make the diagnosis. And then at the end, we're going to end up with two cases and how we make the differential diagnosis. Thrombotic microangiopathies is due to the microthrombi in arterioles, and that's due to the widespread ischemic damage. And this picture is associated with thrombocytopenia, which is due to the platelet trapping and to the red blood cells fragmentation by microangiopathic hemolytic anemia. In other words, when we have a disease which is a situation, a clinical situation by thrombocytopenia and microangiopathic hemolytic anemia, we are allowed to talk about TMAs. And that is associated with a picture of organ damage due to the microthrombi in the very small vessels. And that could be, for example, brain or kidney or any other organ that could bring also to a very severe type of symptoms and life-threatening pictures and leading to the mortality in the patient. So with one term of TMA, there could be many diseases which representing the final common pathway of multitude clinical syndromes. That could be TTP or HUS or drug-mediated TMA or, for example, metabolism-mediated TMA. But what is really the situation is differing is the most important, I would say, question for the clinician. And we have to be careful during the evaluation of the patient at emergency when there is a first episode of TMA to be able to analyze very well from clinical point of view and laboratory point of view and end up with a correct diagnosis and make a correct differential diagnosis. Also because in all these diseases like TTP, as I said, HUS, catastrophic antiphospholipid syndrome, preeclampsia, eclampsia, or HELP syndrome, or even DIC, you would find the low numbers of platelet and microangiopathic hemolytic anemia. But there are few aspects that help us to distinguish, for example, TTP from the rest of them. For example, in the HUS, you have an alteration of kidney function and you have a renal failure. In antiphospholipid syndrome, you're going to find the microangiopathic hemolysis, but you have also prolongation of APTT and the positive LAC and ACA anti-beta 2 GP1. And also, for example, in eclampsia and preeclampsia, that is only the condition in pregnancy and mainly in the first pregnancy. And you can also in HELP syndrome to see that the liver enzyme are increasing significantly. And in DIC, you have a prolongation with PT and APTT, which you don't find it in TTP patients. Let's go to focus on TTP. First, this disease has been described almost 100 years ago by Dr. Moskowitz with the disseminated formation of the platelet-rich thrombi in microvasculature, which was bringing to tissue ischemia, as I said before, in a brain, kidney, and heart, and mainly in brain for the TTP patient. There was also the platelet consumption because there was a severe thrombocytopenia and red blood cell fragmentation, as has been explained in the TMA, that was leading to the microangiopathic hemolytic anemia. What is the epidemiology of TTP? There are two forms, the congenital cases, which are less frequent, about less than 5%, and almost 90 to 95% are acquired cases, with an incidence of 2.2 for the new cases in million of general population, and that data is reported in the Oklahoma Register in the US, and with a prevalence about 30 to 20 cases or 19 cases in Europe or in the United States. The severity of this disorder could be very different in different patients at first acute episode compared to relapses. And usually the first episode are very severe and the mortality is very high. Unfortunately, with the introduction of plasma exchange and immunosuppressive treatment, the mortality dropped from 90% to 10 to 20%. However, since the patients are young patients between 30 to 50 decades of their life, it's very important to understand what are the novel drugs that could have a role in reduction of the mortality and improvement of quality of life of this patient for the long term. Mainly the patients are women, 3 times more, and the recurrence of the disease is about 40 to 50%. And in the rest of the population, our patients, the disease has been observed just once. As I mentioned, the long-term consequences is one of the important issue in the treatment of the survivors of TTP patient. For example, recently we have seen the cognitive impairment, depression, headache, and significant reduction on the quality of life of the patient, especially if they are affected with the recurrent TTP. But what are the causes of TTP and the pathophysiology? It has been established that ADAMTS13, which is a metalloprotease, has an important and key role in the cleavage of the von Willebrand factor, and this cleavage is happening in tyrosine 1605 and methionine 1606 in the A2 domain of von Willebrand factor. And that has a very important role in the blood circulation in order to keep it really clean without any accumulation of ultra-large von Willebrand factor and without any risk of higher, I would say, adherence or binding of ultra-large von Willebrand factor to platelet at GP1B receptor. Because if that cleavage is not happening, this is what has been shown in this cartoon, you would have the binding of the ultra-large von Willebrand factor to GP1B of the platelet, and you have this aggregation and binding of the platelet to the very highly dense ultra-large von Willebrand factor with the also accumulation of the erythrocytes, which leads in blood smear to see the schizocytes in the patient who are affected with the TTP. And here you can see the work that has been clearly showing how the intensity of the binding and hemodynamic forces of ultra-large von Willebrand factor is increased from when is changing from globular form to the fully unfolded von Willebrand factor, and the number of the binding sites are increasing, and the potency of the von Willebrand factor is exponentially increasing for the platelet and happening what I showed you before with the formation of the macrothrombi in the microvessels. And how this interaction between ADAMTS13 and von Willebrand is happening is extremely important, and several researchers in the last 10 years worked on in the docking of the D4 domain of von Willebrand factor and C-terminal region of ADAMTS13, and how the unfolding von Willebrand factor allows the proteolysis within the A2 domain of von Willebrand factor. And recently we know there was 2 or 3 papers, I would say, showing how open Adams-13 has an important role in the physiopathogenesis and also in cleavage of von Willebrand factor, and what are the conditions that could make favorable the opening of Adams-13 and also making the facility for the cleavage of von Willebrand factor. Thrombotic thrombocytopenic purpura, we saw what it is and what is the role of Adams-13 and how that cleavage is happening. And now we are moving to the diagnosis. For understanding what is available and what's the recommendation of ISTH, we have tried with Ilaria to come up with a great approach that has been used by ISTH for the development and evaluation, providing a framework of rating on quality of evidence and grading a strength of recommendation in the structured and transparent and comprehensive way. And you can find this information clearly on the website that has been reported. So the strategy that has been used, it was a PICO question on population intervention, comparison and outcome. And there was a group of experts trying to understand what are the open questions that clinicians need to answer regarding the diagnosis and treatment of the patient affected with TTP. And as you can see, it was important for this expert to understand about the platelet count recovery, relapses, mortality, time to relapse, and whether there is any kidney acute injury, the days in the hospital, exacerbation, which means remanifestation of the TTP in the first 30 days after the recovery and normalization of platelet, and the level of Adams-13. So there are different type of questions this guideline tried to explain, but for example, one of the examples was whether the PECs alone could be enough or the addition of steroid to PECs versus PECs could be an additional value for the immune TTP experiencing the first acute event. And how the recommendation is made for those of you who are not familiar with the recommendation. So recommendation could be strong against or could be a strong recommendation for intervention. And then you can have the conditional recommendation for the intervention or for the comparison. The two recommendations, both on the diagnosis and treatment, has been published recently, as you can see, in July 2020, and has been clearly reported during the ISTH meeting this year, which was virtual. So what are the laboratory features that you have to know for the diagnosis of TTP? We need, as we said, to confirm thrombocytopenia, and the level of platelet count could change and usually are less than 20,000-30,000 when the patient is as a first episode of TTP. And this picture should be associated with the hemolytic anemia, increased LDH, indirect bilirubin, consumption of haptoglobin, and also we have to make sure that the Coombs test is negative. It's important to have a look on the peripheral blood smear and look for the schizocytes, which are more than 1%. Once there is confirmation of low platelet number and hemolytic anemia, then it's important to understand what are the clinical features of patients with TTP. And TTP is a multi-organ disease with very variable clinical features. And that makes extremely difficult for those who are not familiar with TTP to make an easy diagnosis and very quick diagnosis, which is important in the rate of the mortality. And in the first 24 hours, you should be able to make the diagnosis because, as I said, the mortality could be really improved for the very fast initiation of the treatment. So the first type of symptoms are systemic symptoms like fatigue, fever, abdominal pain, headache, vomiting, jaundice, and the patient when it's the first time, might not even understand what's happening. Maybe could be misdiagnosed by a simple fever, and that's the reason why the patient is starting to make some of the bench drugs and go on, and later on coming with more specific type of symptoms like bleeding, and the most important bleeding symptoms is purpura and ecchymosis, and then cardiovascular, which could be acute coronary syndrome, and neurological syndrome like a stroke, seizure, coma, and also the personality change or focal neurological sign and transitory ischemic attack, and not associated with the CT scan, change in the CT scan. And sometimes you can see acute renal failure, but that's not very important compared to the HUS. So these are the clinical picture that you can see. The indicators for the mortality in acquired TTP and its severity is age of the patient, when the patient is older than 60 years, the severe CNS involvement, high levels of LDH, and the cardiotroponin level more than 0.25 microgram at presentation. And that could increase 3 times the risk of the death or refractoriness. So if we have to keep in mind the clinical assessment, we have to consider then the number of the platelet and the level of hemoglobin, renal function, blood film with the increased number of the fragmentation and schistocytes, and the alternative diagnosis, as I mentioned first, with the differential diagnosis with other microangiopathies should be done. Is it enough with what I told you about the clinical manifestation and the laboratory feature, the simple laboratory features that I showed you? I would say that help a lot. For example, the French and plasmic scores predict the likelihood of severe Adams-13 deficiency, particularly in those patients that you have the suspicion of TTP. However, the use of this formal risk assessment could not substitute the measurement of Adams-13. This is the first message that I want to leave, and that's a very important message of the guideline. The use of the formal risk assessment model could support the clinical judgment, and you do not need to wait the Adams-13 test, and you can start to treat your patient with plasma exchange, we will see later, and with steroid or any immunosuppressive that you're using. But keep the samples, and also you need to make sure that the level of Adams-13 is low and you're confirming the diagnosis. And this work, which has been published by Dr. Scully in 2015, was showing similar things. When you have a patient with thrombotic microangiopathy, when you make the hypothesis that the patient could have TTP, then you need to make a distinction, as I said, the differential diagnosis with hemolytic uremic to look on the kidney function and to measure Adams-13. And if the level of Adams-13 is less than 10%, that is confirmed the patient has TTP. And if the level of Adams-13 is not confirmed, you're not allowed to talk about TTP. And that's a diagnostic flow chart that we are proposing, which is simple. The patient got to the emergency, you visited, and you made the lab exams that as we showed, and clinical evaluation of the patient. Then the diagnosis is hypothesized by you, and then you make the evaluation of Adams-13. And if the level of Adams-13 is low, you have to evaluate Adams-13 antibodies. And if the level of antibodies is measurable, you can define and is positive acquired TTP, and if is negative, you can think about the congenital TTP, and you have to look on the family tree and understanding whether there was any consanguinity and the patient is coming from the region of the world that consanguinity could be higher, or eventually 2 heterozygous carriers, they had children with affected patients or child with TTP. There are 2 slides that I want to show you, and it's important to follow. And that's ICH TTP guideline, and I think it's very important and is easy. As we said, you have a patient that has low platelet number and hemolytic anemia, you evaluate the probability of the TTP with the scoring system or with the clinical judgment and assessment, risk assessment model that you want. Then the patient is with low or intermediate, less than 90%. There is the probability of TTP, but is not really, the risk is high. Then you consider to get a plasma sample, start plasma exchange and treat destroyed plus plasma exchange to send your samples out for Adams 13 measurement. And if the level of Adams 13 is low and is getting within 72 hours, then you can start to think about the results and wait for the result, and also for the anti-Adams 13 antibody. And do not start caplacizumab and wait for the Adams 13. If the level of Adams 13 is low, then you are allowed to add caplacizumab to the treatment that I was mentioning. But if you are in a center that there is no possibility to have Adams 13 in your center, or even with the help of any centralized lab that could get a sample back and its result back, then you do not start the caplacizumab treatment. What about a patient when the diagnosis has been evaluated again with the risk assessment model, and the patient has a high risk with more than 90% of probability of having TTP? In that case, you start plasma exchange and steroids, and again, you can keep the sample out and add to your treatment caplacizumab, consider early caplacizumab therapy, and also wait again for the Adams 13 measurement level. Follow the triplet type of treatment that you have started, PEX, steroid, and caplacizumab. And if the results of Adams 13 coming back and is less than 10%, you continue with caplacizumab. And if the level is more than 20%, you stop with caplacizumab. And again, if you are in a center that have no facility of PEX or even the measurement of Adams 13, I don't think there is a good choice to start with caplacizumab, because you have to be able to manage the drug. Let's go to have some explanation about how is the situation in the clinical situation and how you have to make the differential diagnosis. We have two cases, two women in the emergency department. The first case is an 80 years old female is getting to the emergency with confusion and malaise, and with a blood pressure which is normal, 115 to 75, and with a rate of 100. Oxygen saturation is 93%. And the respiratory rate is 32 per minute. Patient has pallor with past medical history, which is not really reporting clear, I would say, diseases. The second case is a woman of 47 years with confusion and visual disturbances, with a blood pressure of 140 and a minimum of 80, heart rate of 110, oxygen saturation of 98% in room air, and with a breath respiratory rate of 30 minutes. This patient is coming with a neurological alteration and left lateral hemianopsia, and the past medical history of this patient shows 2 uncomplicated pregnancy and obesity. What you do and how you are going to analyze the patient. Until now, it's difficult to make any kind of diagnosis or even early diagnosis. You need definitely to look for laboratory tests, and you need also to make ECG and the brain CT scan. In the first case, You have the CT scan showing the white substance chronic alterations with the sinus tachycardia, with anemia, 4.7 of hemoglobin. White blood cells are not significantly increased, and there is a mild platelet consumption between 32,000 to 76, and with a creatinine level which increased about 163 to 2.18, and the total bilirubin level is increased, with the LDH level significantly increased, and partial increase of the PT and the D-dimer are also significantly increased. In the second case, the brain scan shows the right parietal temporal hypodense lesion, again with a sinus tachycardia. Even this patient, this woman, is anemic with 7.5 of hemoglobin, and the platelet count, which is lower compared to the first patient, about 16,000 to 19, and the creatinine level more than 2, with the increased level of LDH and D-dimers. Here, then you have, in both patients, I would say you have anemia, hemolytic anemia. You have also low platelet number, however, the severity is not similar. And in one case, you have also alteration on the CT scan. So you can think about that both cases, they have the TMA. Neurological, same sign and symptom, hemolytic anemia, low platelet, and renal impairment. What else we have to do? Coombs test is important. Peripheral blood smear for the presence of schistocytes, haptoglobin for the confirmation of hemolytic anemia, and also urinoanalysis has been done for the protein and blood. And finally, we talked about for several slides that I showed that differential diagnosis of TMA needs the evaluation of Adams-13. So in the first case, the Coombs test resulted positive, and in the second case, negative. We don't have the schistocytes available. We have Adams-13 that has been sent out, and the results are ongoing. We have measured B12 because there was other type of examination like MCV showing the size of the red blood cells were bigger than what we are expecting. And then we made a supplementation of the P12, but we haven't seen the improvement, and the platelet count in the first patient went down. So at this point, the confirmation of TMA is there again. And in the second case, we can see that the Coombs is negative. So again, the TMA could be still confirmed and is not excluded. So then finally, we have the results of Adams-13. In the first case, we do not wait for the results of Adams-13, and we start immediately PEX treatment and steroids, and even in the second case. But we are waiting, looking forward for the results of Adams-13. In the first woman, the first case, the Adams-13 resulted 38. Then we are looking and reconsidering the diagnosis. The final diagnosis is megaloblastic anemia with atrophic gastritis, cold agglutinin disease, immune thrombocytopenia, platelet consumption, or urinary tract infection. So one of these could be the diagnosis based on what we have seen on laboratory results of this patient. And in the second case, with the low level of Adams-13, we continue the treatment that we have started, and we add caplacizumab. And actually, the reason why we added, because we did not have it at the beginning, but this case you can start immediately like caplacizumab, evaluate the severity and the further treatment. And here I want to say that, of course, it's very important that you start the triplet of the treatment PEX, immunosuppressive, and CAPLA, because you are shortening the time of the thrombi formation in the vessel and neurological damage or renal damage or cardiac damage. And if the level of Adams 13 was not less than 3%, we were allowed to continue with PEX and steroid and stopping caplacizumab. And this was what I tried to show for the management of the patient affected with TTP and differential diagnosis of the patient with a TP. However, there are lots of information that has been reported in the guidelines of TTP for both aspects of diagnosis and treatment. And I would like to invite you to read these papers because I think they are very informative, and that was a really big effort from the ISTH to prepare these two guidelines. And I hope this lesson were useful for you, and I'm happy to answer any question by the emails that you can send to my email address. Thank you very much.